important session on London Global Cancer Week. We've been participants of London Global Cancer Week since its beginning, and we're delighted to continue. We now have to compete. It's not almost automatic, so we're really pleased. C3, and many of you will know this, is a small charity working globally to combat chronic disease, NCDs, by a real focus on prevention, and particularly the risk factors: smoking, the diet we eat, and the lack of physical activity. And we have, since our very beginning, run international seminars, initially in person, and therefore most of our audience was from the UK and even from London and London area. And it was very much so that we could learn from the experiences, the successes, and the challenges of people from other countries. One of the advantages of COVID, perhaps, is that now we're all used to many more meetings online, and our international seminars have now continued as online. And as a result, of course, we get many more participants from various places in the world, including the rest of the UK, but also from far and wide. The disadvantage, of course, is nobody gets one of the famous C3 healthy breakfasts, but we are able to hear from and reach many more parts of the world and much more expertise. And that's what today is about. So finding a speaker on prevention in the nature of cancer and its impact in the world always feels more challenging than for many other conditions, because quite properly, there's a strong focus and anxiety and pleasure around the advances in cancer treatment and cancer care. And often cancer prevention is less thought about than preventing in other areas of health. So we're particularly delighted to welcome Dr. Alfred today with his experience from one of the poorest countries in the world about cancer prevention, and particularly building cancer-resistant communities, focusing on community cancer services, which is his expertise, his research background, and which is so relevant to people in this country, where our government, I have to say, like many governments before, wants to put the emphasis on prevention. And too often that's about fine words. But Dr. Alfred today is going to show us real action and real results from a community approach to global cancer prevention. Dr. Alfred, thank you so much for joining us. We're really looking forward to hearing you. We've had the inevitable one break in the internet transmission, so we should be fine for the rest of the seminar, and looking forward to hearing from you. And thank you again for giving us your time and most of all your expertise. Thank you. Over to you.
Thank you so much, Christine, for the warm welcome and introduction. And also thank you, the listeners who have tried to log in to listen to me. I also thank you so much, the team in the London Global Cancer Week, for sending that invitation to Uganda to have something to say. Oh.
Hello. We may have lost you, or we may just have lost your sound. Maybe Una, can we switch?
So hopefully it's just the sound. Do you want me to share to try and reduce the load on the internet?
Yeah, maybe.
Dr. Alfred, if you stop sharing, I'll share. Oh, it's gone.
That might
Hopefully
be.
you'll come back in.
Yeah. But if you started sharing, maybe that would help.
Just
he is.
Yeah, back in.
So, Dr. Alfred, we wondered whether if we took over the slides, that would reduce. Is that you now, Una?
I'm sorry, the internet. I'm sorry.
That's all right.
Is that the internet now? Yeah,
great.
Sorry.
Listening to you. Yeah, fine now. Thank you.
Okay, let me try. You're able to,
I'm sharing
able to see the screen?
You.
So we're managing the screen now because that feels like it might lower the weight on your internet connection.
Okay, fine.
So you'd have to say next.
Yeah, the next slide.
Great.
So generally, in just like in other low-income countries like Uganda, cancer still remains a public health problem, and you're seeing rise in the incidence and also the prevalence. Rise in the prevalence means there's more load on the healthcare system to meet the healthcare needs of these people, and yet the government allocations. Christine, you're able to get me?
We can do the next slide.
No, Christine, are you hearing me?
Oh yeah, we're hearing you.
Yes. Okay.
No problem.
So putting a lot of load on the healthcare system, which is struggling with both the infectious disease burden and also a rise in the NCDs, just like the same in other sub-Saharan African countries. Next slide. This is a typical example for Uganda, where you see the new cancer cases per year, the incidence. This is age standardized data, average of 35,000 people per year. And then the expected deaths around 24,000. And then the 5-year prevalence, 77,000. These 77,000 people reflect people that need to receive treatment. So this is quite a huge number vis-a-vis the amount of money allocated to the Cancer Institute to take care of the cancer control services in the country. Next slide. Next slide.
Yep, there we are.
So when you look at our cancer statistics, for example, among the women, when you press next slide, you're going to see, when you press next, you're going to see highlight among the females, 2 types of cancer of the cervix, a cancer of the breast, make almost half of the cancer burden. And yet these are 2 cancers that we have some known preventive measures, and also there are well-known screening methods that are available for them. But these are they remain inaccessible to the people due to some of the high cost of these screening devices. So they need to look around what are the low-cost options which can be feasible within the community, and how can you work together with the community maybe to mitigate the impact of this constraint on the healthcare system. Next slide. So when you look, this slide trying to show you the top cancers in the country, and then the relationship between the incidence of cancer and then the mortality. Of those new cases arising, what the proportion of deaths occurring within the same year? When you see the red is almost close to the blue, it means almost everybody could be going. But for certain type of cancer, where we have tried to really done enough intervention in terms of screening, though not to the scope of the developed countries, we are seeing at least the blue is taller than the red, meaning we are trying to save more people. We are like to save more people in a given year compared to the number of people dying. Next slide. Then this one is showing a trend from the population-based cancer registry, the one in Kampala, which is called Kampala Cancer Registry, where the capital is and also where the main comprehensive cancer center is located. Some of the cancer that we've been targeting them with some intervention, they're trying to show some degree of sloping, but they still remain high overall because the high volume cancers. Other cancers we use not to be targeted, like cancer of the esophagus, cancer of the colon, they remain shooting up in both men and women, as you can see from the graph there. And yet those are very little cancers, not comparable to cancer of the breast or cancer of the cervix, where you can easily treat and cure the person. Cancer of the esophagus, cancer of the liver, they are very dangerous, including cancer of the colon. Next slide. These are just highlighting the female cancers. So here, generally, okay. Next slide. So this one, what are the cancer control challenges in the low and middle income country like Uganda? Some of these challenges also even are being exhibited in high income countries, except that the level of allocation and the nature of the healthcare system, how they manage the healthcare system differs. But many of the low income countries in Africa have these kind of challenges which I have summarized. Either political crisis or civil wars, which affects the development. Any development put in place in the area of disease control, defined civil wars can affect it. And then we start rebuilding. Uganda is one of those countries that had what we call load-resistant army war in the northern Uganda for 20 years and affected the healthcare system. And therefore, you affect even healthcare infrastructure to fight cancer. Even other neighboring countries are in the same confusion. Then at the same time, the inadequate number of specialists, particularly oncologists and other critical cancer experts that are required for right from prevention to care. I'm trying to look at the bigger approach, not just look at the prevention, because when you prevent or when you detect even early, to detect early also need specialists. But when you detect early, also need oncologists who can provide timely treatment to help this person. So that's a holistic picture I'm trying to look at. So all those critical mass of healthcare workers remain very, very inadequate compared to the need of the population. Then the high cost of training these cancer experts. In Africa, many of the African universities, the hospital, they lack training center for critical expertise, like in cardiology, in cancer control. So many people are trained from Europe, trained from UK, trained from the US, or trained from Asia. And that cost of training is very, very high, which our government, for most cases, cannot allocate resources to train such person. So the oncologists we have in Africa, for example, the one you have in Cancer Institute, have been trained in Europe, have been trained in the US, and in Asia, with the funding coming from abroad. So this remains a big challenge for cancer control, right from prevention. Overall inadequate funding, even high cost of anti-cancers. There is no single factor is making anti-cancer in Africa. All these anti-cancers come from Europe, Asia, and America. So when you look at the shipping costs and so on, and then when you're consuming less volume, the manufacturers charge you more money because you can buy cheaply based on economy of scale. If you're buying a lot, then there's some kind of discount for you. When you're buying for fewer number of people, not just because there are fewer people having cancer, but you have little money to buy enough. So that creates a lot of problem. And then over centralization of cancer care hospitals. Like in Uganda, the only comprehensive cancer center is the Uganda Cancer Institute where I work, which provides comprehensive cancer care. All other people across the country and the neighboring country that seek care in Uganda have to cross to this center. This makes access very, very difficult amidst the little resources allocated by the government. And yet cancer area, like other NCDs, they rarely attract money from the donors, from the international partners. Many of the international partners providing funding in Africa, they focus on infectious disease, HIV, AIDS, and malaria. So that creates a constraint. So given, next slide. So given that challenge, building a cancer-resistant communities approach need to be one of those options we should be exploring on how it can be helpful, both in a low-income country and even in high-income country like the UK. The concept of cancer-resistant communities relates to the concept of herd immunity. Herd immunity in the vaccination immunization means if some significant number of people is protected, overall the burden of that disease will be manageable, will be put under control. So cancer-resistant communities are meaning communities where we are implementing public health efforts that are focused on cancer risk reduction as a priority, reduce the risk of developing cancer through non-intervention. Like, for example, we know that tobacco causes cancer. We know alcohol causes a number of cancer. We know lack of physical activity increase the risk of a number of cancer. We know unhealthy diet increasing a number of cancer, increase the risk of a number of cancer. We know exposure to certain pollution, poor air quality increases risk of cancer. We know our rural communities are cooking using firewood, a biomass, which produce a lot of smoke they keep inhaling all the time, increasing the risk of cancer of the esophagus in their country. We know infection like HIV, like human papillomavirus is responsible for the cancer of the cervix. HIV also increase the risk of cancer. So public health efforts that try to reduce exposure to those risk factors help to cushion the community so that they're cancer resistant. Or if prevention fails, we find the cancer early enough where you can do simple intervention like pre-cancer treatment for cervical cancer, which this woman will not undergo surgery, will not need the chemotherapy. You can find this cancer at the stage of dysplasia and deal away with the dysplasia through cryotherapy or thermocoagulation. That is much more cost-effective and also cushioning the communities against the impact of cancer where they don't have enough resources to take care of themselves. And also for those with the late-stage disease where we may not prevent, ensuring that the community can provide support services to mitigate the impact of cancer within that specific community. That's a very important concept. But that concept works well, or the model of cancer-resistant communities building works well when you consider that community first approach should be the mindset. That is the concept of working together with the communities, co-creation with the communities. Look at affordable option that the community can afford to also contribute resources to cancer control, because the money allocated nationally.
Would you like us to move to the next slide? I think possibly.
That dropped off. I think his internet may have dropped back out, so hopefully he'll pop back on.
I think we could start so there's a series of slides now describing the approach with its principles. Maybe we should move slowly through those while we wait for Dr. Alfred, hopefully, to reconnect.
Okay, just let me know when you want me to proceed.
Yeah, I think put up the next one. Which has quite a lot on it, and we could leave that for a short Ah, here we are, just back in time. So, Dr. Alfred, we've just moved your slide on one.
Okay, okay. Sorry, I'm back.
You are. Great.
It is the internet strength, no longer the power, but the internet strength fluctuating.
So keep going. Great. Thank you.
So let's look at the principle of the community first approach. One, the co-creation. It requires working with the communities in terms of agreeing on the initiative, the strategy that can work for them, and then understanding the local context of the intervention, and include the healthcare system. For example, to screen for cancer, screening for cancer of the breast in the developed countries, everybody speak about mammography, but mammography is very expensive to afford in Africa. But the number of trials done, like the Peruvian trial, and then the trial done in India, that shown that training primary care workers on how to do clinical breast exams can yield a similar result in terms of effectiveness to detect breast cancer early. So those are the local context issues that should be looking at if you're to really to build a community which is resistant against cancer. With the principle of community first approach, should understand what is applicable in their own setting. I put this book for you to people can read it later on, called Africanizing Oncology. This study was done in Uganda by Marisa Mika, a lady from the US. It was part of her PhD after the PhD study, which shows how Uganda, being a poor country, but has been in terms of there have been almost failure in the different aspects of the healthcare system. But in the cancer control segment of the healthcare system, Uganda has been resistant in terms of building infrastructure for cancer control, even during the civil wars of the Uganda, but trying to look at the community context, what is applicable. As I speak now, Uganda, the East African member states agreed, all the presidents of East Africa agreed that the Uganda Cancer Institute be the center of excellence in East Africa for the other member states to learn from, based on certain degree of how to work with the communities, how to translate the biomedical science in the context which is affordable, applicable, and easy to implement in the culture of the people. This is what we call understanding the local context. Next slide. Tailored intervention. For example, the message you're giving to the communities should be tailored to their context. A number of research done across the world, which are normally picked and pasted on the particular communities. You could have a community in Europe, but the study may be done in the UK, but put on the other community in Europe, which is not the UK. So that one does not help well the communities. But when put into their unique characteristics, okay, it will be a better approach in terms of building a community which is cancer resistant, and also building capacity of the local system, the local leadership, the local primary care workers. Many of the people worldwide, they look at issue of cancer control, issue of treating cancer, issue of controlling cancer. That is the work of the oncologists. Not everything requires oncology.
I think, Una, we could move to the next slide while we wait, hopefully, for Dr. Alfred to reconnect or to be reconnected. It's really interesting already, I think, some of the messages that are so relevant to us, certainly in the UK, where the take-up of screening within minority communities is often a really big challenge. And in many ways, it's not surprising. Some of the screening is really uncomfortable and unpleasant. That's across the board in cancer, but perhaps particularly around breast and cervical cancer for women. And we've tended to focus our efforts, probably rightly, to persuading more women to be tested. But I think often people underestimate the unpleasantness of the screening approaches. I heard a really quite amusing presentation from a public health person recently describing how if various bits of the male anatomy were put into the same processes. Right, I'll allow Dr. Alfred to continue.
Okay.
Great.
So focusing on integration, the concept of integration is many people try to implement a single project, a vertical approach. Maybe you say tobacco control alone, you budget for it. Alcohol control alone, vaccination alone, maybe weight reduction alone. For low-income communities, even the high-income communities, there are also subpopulations that may not be particular communities, that may not be like maybe certain community within the particular well-developed areas. So when integrate the interventions, it becomes much easier to deliver to that population. It becomes much easier to implement, and it also becomes much easier for the community to take action upon. For example, when you mobilize community, you want to speak to them about tobacco control. Then next time, the same community, another group of people come speak about alcohol. There's so many risk factors in the world. It will become too much for them. No human being is born just to be there living, addressing issue of health only. They also have other life to live in the world. So when integrate the services, the package, you package the service, integrate it, it becomes much easier to deliver to the community, and maybe at the cost that can even afford where it is paid for. And also building trust of the healthcare system. We need to make sure there's a trust of the healthcare system, there's a trust of the interventions. Many people lost their trust during the COVID-19 pandemic, where there was no trust in the vaccine. Even the healthcare professionals themselves, we are fighting among one another in agreement. So many, even some top politicians were also in agreement with that create mistrust to the population. So make sure we build trust, and you deliver only intervention which is not harmful to the population. We know this is what is proven that can save life. And we are also exhibiting that you're also uptaking those services. You cannot say you are health workers, you want to deliver these interventions to the communities, but you don't take those services. You don't vaccinate yourself. You don't allow your daughter to be vaccinated. You say do not smoke, for you are smoking. You say don't drink alcohol, for you are drinking excess, they're seeing you. So that is element of building trust. If you know this is the intervention that works, we should also exhibit that and make sure that the trust in the intervention among the leaders and the people who receive it. Next slide. Then partnership, very important. For the last 10 years in Uganda, I've been working with the community because you don't have the resources to screen everybody for cancer. But we've been working with the communities and local partners. We normally view partners as the international bodies under the UN, the USAID, the UK AIDS, maybe Japan, the JICA, what they call the JICA, Japanese Cooperation Development. The partners should also include the local communities of some resources that can raise. It may not be a physical money which they can pay, but there could be some resources within that community that can support cancer control activities, that can support reducing risk of exposure to things that can increase the risk of developing cancer, or resources that can help people to screen themselves for the common type of cancer. That is working as partners, which I'm going to show later on. And then utilizing the available primary care workers who are not oncologists. There are a number of interventions under cancer control, especially in the area of prevention, early detection, that do not require oncologists. Those interventions, screening, basic investigation, when you suspect cancer, should be downloaded away from the hand of the oncologist, but shifted to the primary care workers, because these are the people who meet the health workers on day-to-day, in the day-to-day. And the primary care intervention, like for example in Uganda, are much cheaper and at times even at low cost. So you can end up reaching many people to reduce their exposure to cancer risk factors, or maybe to screen, especially the common type of cancer, using the screening option that can be feasible in low-income countries. Next slide. Next slide. Now, how do you put this into practice? This paper is available and published in 2021, where we look at between 2015 to 2020, we work with the community as partners using a concept called the asset-based community development model. This model I read about was published by one of the scholars in the UK many years ago. Then I expanded the concepts of that ABCD model that within the community some resources. We look at if you have to budget for every cancer control intervention, every screening intervention, and then you say government to give her the money, the government will fail to give her the money. But there's a number of resources like infrastructure, the shade, the mobilization cost, which are available in the communities. Our community have local radio station. They have what they call community audio towers that we can pass information onto. And you can get that one free of charge from the community if you say it is for the health of your population. Those are cost reduction interventions. We have already health volunteers in the villages who normally volunteer for other health issues like HIV, malaria, and so on. If you can train them and give them a package, a summary information, order to speak about cancer, that's already a free resources in the communities that you can make use of. There are some community-based organizations providing any other local services. If you say cancer is also a problem killing our community members, can you put part of your little resources, part of your fundraising to support screening of your population? They would do that. And you tried it, it worked. Next slide. So this is a finding of that asset-based development model. This is published in the e-cancer. So I think, let me see the journal. It is published in one of the journals where we demonstrated that when we work with the communities, build their capacity, also they contribute in some of the resources, not just physical money, so that the little money you get from the government can only handle maybe some of the cost of the intervention that the community cannot afford. You will be able to reach much more people. When you look at this pie chart, from 2015 to 2019, we added all the total money we got from the government of Uganda. We found that it could only deliver the one you see in the red. But the biggest blue area there, it was screening intervention we did in the community across the country that was supported purely with the resources coming from the community. And the communities have been prepared, prepare their mind, this for your own health. If the government does not allocate enough money to fight cancer in your community, I call it cancer fighting because cancer is a bad disease. If the government doesn't give enough money to fight cancer in your community, the cancer is not affecting the government. The cancer is affecting you. And the person in that government is a person who earns a lot of money, is the one who controls your resources, will fly him or herself to the UK, to the US, they will fly to India and sort their health issues. But you will be affected. So community have been supporting. And you see that kind of the result of the intervention as way of building community which are resistant against cancer, but working with them to leverage the resources to make sure you meet the needs. And the need is their needs. Next slide. So at the same time, we need to build the local leaderships. And also make sure the intervention that we do, the communication that we are giving to the community, the messages we are sending to the communities are culturally appropriate for the communities, so that they are able to see that this is our problems and this is our health intervention that we need to embrace. And in this context of cancer, more focus should be on prevention and maybe screening to find the disease early. If screening fails, then early diagnosis, people to seek help immediately, educating them to be aware of some of the warning symptoms of cancer and alerting them once you see this, go to higher level hospital, not small clinic, and try first suspect cancer. When they find the problem not cancer, be happy, well and good, that is good. But if the problem is cancer, you like to be held when the cancer is still in early stage, which you can treat and cure and return it to productive life. than wasting a lot of resources dealing with the late-stage disease, which will take your personal resources, take government resources, take health workers' time, but no return on investment. Next slide. Yeah. Then this one now, in the context, still concept of building cancer-resistant communities in terms of how to implement the interventions. A number of health education awareness are required, raising local resources from some of the individual themselves can contribute their resources, or community-based organizations, empowering the communities through the healthcare system, particularly the primary care workers, and then ensure that there's a network between the oncologists at the National Cancer Center and the primary care workers in terms of evidence-based intervention, letting them to know what works, what does not work, at the same time balancing the supply and the demand. Balancing supply and demand is the concept of avoid over-raising awareness about screening when you know the screening intervention, the screen tests are not available in those facilities. Because when the community go, they'll get disappointment that you told us to do ABCD, but you didn't find the what? Maybe the health worker to screen us. The health worker say they are not knowledgeable or not trained to screen for cancers. So you must balance that. You have certain number of health workers trained to deliver this. They have some available supply that can provide the services, and then you can raise awareness people to what to consume those services. That is balancing supply and demand. You don't balance supply and demand, you cause distrust into the healthcare system, where people come and don't find the services. Instead, for example, in Africa, they say they rather go to the herbalists or the witch doctors who will say they have solution for everything than going to the healthcare system which does not have solution for you. Next slide. So this is an example of building health literacy, improving the health literacy of the healthcare system, training health workers. We developed a number of materials between 2018 to around 2019, distributing them countrywide to the primary care workers to use. We're also developing a number of flyers and brochures, which we give to the health volunteers, which we call the village health teams, and also what we call community health extension workers. They are non-health professionals. They're not health professionals, but they are volunteers who have come up. They are either retired teachers, retired health workers, or any other person who did not go higher in education but in living in that particular communities, but they're able to offer their time to sensitize their fellow communities about cancer and other disease. We train them, then give them some package information to help their communities know how to reduce risk to cancer, and when they suspect cancer, or also telling them which type of cancer common in their sub-region they need to screen for. These are a number of materials. We publish them in these papers, one of them published in eCancer, then one of the paper on capacity building published in Cancer Medicine Journal. And now we are working with through a funding from Sanofi and TET. TET is their new name is Global Partnership for Health, which is supporting also training of these healthcare workers. We are retraining them again, and we develop a training package which we'll use for the entire Africa. Uganda working together with Zambia to lead onto this. This is a booklet you are seeing here attached to the extreme end here, which is saying community simplified version for the community health workers and then for the primary healthcare workers. All those are ways of building the health literacy of the health system itself, and also the health literacy of the population, so that people are aware about the cancer risk factors. They're also able to take actions, go to nearby health facilities to get screened using low-cost screening intervention. At this level, I don't speak about mammography. You speak about clinical breast exam. You speak about cell breast exam, that once every month examine your own breast. You can also help yourself if you cannot afford going to the hospital to screen yourself. When you find problem in your breast, come very fast to the nearby health centers or hospital to do additional tests on you and advise you accordingly. And also area of like cancer of the cervix, other developed countries they are using pap smear, HPV DNA testing. Those tests are also available here, but very expensive. So we reserve them to people who can afford to pay for those tests. Other people cannot pay. We use the recommended VIA, visual inspection with acetic acid, which is much cheaper. You can screen each woman at the cost less than maybe £1 or £2 per woman, which is a bit affordable, and therefore you can still help to reduce, to mitigate the impact of cancer in these communities, just like in the developed countries. There's a number of information for the children, for so many of them. Next slide. This one, our community outreaches. We have a mobile bus, that yellow bus you see. It has a mammogram in it. It has a portable ultrasound machine in it. So once in a while, for the people here which you can access, we drive and go to those rural, remote communities, station there for 1 week, and provide free screening for them, free mammogram, free ultrasound scan for people with suspicious lesions. Yes, you can also do PSA tests. And for the main, those are the common cancer we have in our country. For other cancer that you cannot screen for, people come with early warning symptoms, we initiate investigation and navigate them through the healthcare system so they're able to access the care they need. People cannot afford the care, we link them to some of the local leaders in their areas, local churches that raise some money that can afford to give them transport to take them to the cancer treatment centers to mitigate the impact of the cost on the families, trying to build a cancer-resistant communities amidst a low-resource setting. Next slide. Yeah, okay, maybe back to that slide. You see the person speaking there, is this Alfred. Back to the previous slide. You see the person standing here speaking to the group of students in the school. That's a school health program. We also have run a school health program and a concept called 3 C's, that is CCC, children caring about cancer, so that they get to know some of these risk factors I was speaking about: smoking, alcohol, exposure to viruses like human papilloma virus, which are passed through sexual intercourse, hepatitis B, that causes cancer of the liver. These children they are now sexually active in school. They can get exposed at that particular age group. Then they will develop the cancer 20 years later. So you make sure they also school health program speaking to them. This other picture is showing training of healthcare workers, the one you see in the hall. The other people lining up, they're lining up for cancer screening intervention in a rural area where you have gone in with our buses to screen the people, trying to reach the people who cannot afford to take care of their health because they are either socially disadvantaged, economically disadvantaged. Next slide. This slide is showing us reaching also the school with the school health programs, particularly on the preventions. This was the most recent one. This is one of our nurses providing the health talk and also demonstrating to them how they can do their cell breast exam. So when they grow into adulthood, they know some of those basic health interventions. Cautioning them should not smoke, don't drink alcohol, because those things can lead to cancer. Avoid unhealthy sexual behaviors because you can acquire hepatitis B that can later on cause cancer of the liver. You can acquire human papilloma virus that can make you develop cancer of the cervix, cancer of the mouth, maybe penile cancer later in your mid-adulthood. So those are the interventions trying to building a resistant communities that are resistant to cancer to reduce their risk of developing cancer. Next slide. This is our community outreaches using tent, using the mango. You see that mango tree providing a shade. That's a resource already. Because if you have to put our money, you must hire a giant tent, pay a lot of money for the tent. But if that mango tree is there, it's providing a shade for the people who are waiting for the shake-up. People have gathered, listen to us, speak it to them. That's a community resources. Those school, the rusted iron sheet you see up there, this is a school block in a particular community. We are using those spaces to screen the people where there are no spaces. All those are community resources that you can build on to reach the people. Next slide. This is recently our training, which is funded by Sanofi through TET, which is now a global partnerships, where you are training healthcare workers in 14 districts of Uganda, 7 districts in the western Uganda, and then 7 districts in the northwestern Uganda, to improve the level of health literacy in the community, build the capacity of primary care workers to provide the basic screening that they can do in their communities, also training the health volunteers. After training them, we are giving them certificates. in the extreme right-hand side, that person standing in some coat there in the corner, that is Alfred, the one speaking now. We are giving certificate to them after the training. The TET headquarters, even in the UK, TET. I think Richard is part of the team, the Global Partnership for Health. Yeah. So this is part of the work we are doing in the communities, trying to build a cancer-resistant communities, but with the concept of community-first approach, doing what works for them, integrating based on the local needs in the culture of the people with the spirit of sustainability. Next slide. Still on, I already explained some of this slide I already explained. I wanted to bring a concept of now, next slide. My slide not moving. I think the internet. Yes, I want to bring a concept of what they call building. There's a building cancer-resistant community to reduce the risk or find it early. But also, our people, there are people who develop cancer, but the helpless may not afford the care. They also live in our communities. So there's another concept called building compassionate communities. Building compassionate communities, we are meaning encouraging individuals or groups or community-based organizations within the community to proactively support one another through life-limiting illnesses. Those who have life-limiting illnesses, where they cannot afford the healthcare system due to the cost, or the cost may be minimal, but the distance to access the facility. Or you go to the hospital, they say, fine, the doctor has seen you, but you don't have the drug is out of stock, you need to buy. Some of those people cannot afford it. So we need to encourage communities that can take the care of one another. There's a growing burden, especially in the developed countries, whereby life is tending to be that every person for himself. Life becoming to be too capitalistic. The concept of communitarianism is dying. The concept even of family is dying. Even your father, even your brother cannot take care of you. That is unhealthy world. A world where you live a life of can I call it individual life? You don't support others. Oh, one person accumulate wealth to name himself the richest man in the world, the richest man in Uganda, the richest man in UK. But that money is accumulated in the bank. They fly themselves, they enjoy the world. But there are people who are helpless, suffering in the communities. We need to support them. So that concept needs to be ingrained in the communities. They need to help one another, particularly in a life-limiting illnesses. There may not be many basic diseases like malaria, HIV, TB. Individuals can sort in themselves. But cancer is a very complex disease, very expensive to treat. It makes people to lose all their family resources. They sell their properties. And yet when they can come together, first of all, it's not a very common disease that you will find everybody in your local village is having the disease. Can be one person in a group of 50 to 100 households, maybe one person in 2 or 3 years' time. It means if you can contribute little resources in one way or another, we can save this person. Or whether the disease is late, we can make this person die better with some pain relief, some palliative care for the person. That is a concept called building a compassionate communities. Next slide. So the key principle in building a compassionate community involves public health framework, that community health or heal health or caregiving process or even the dying or death and grief is a universal problem, is a social experience. When one person in your family is sick or unwell, the relatives, the wife, the spouse, the children, they're also suffering. So the social, your own friend is unwell with a life-limiting disease like cancer. You also will never be okay, except when you are just, I can say, but animalistic, not human. But if you're humane, it should also have a touching on you. So that concept is ingrained in the public concept of shared responsibility. a community empowerment, holistic care, that care and support should extend beyond the medical treatment, but there's some social aspect, emotional aspect of the care, spiritual well-being can be provided by the community members to their person who is suffering for this life-limiting disease. That is the concept which we are calling compassionate communities. Next slide. So even compassionate communities can have focus on detection of the disease. For people who cannot afford to screen themselves, you can extend it to them. And then encouraging systemic change. That intervention that they provide need to seek a broader societal change to ensure compassion is integrated into all aspects of life, not the capitalistic aspect of living life on earth. Then education awareness is very important. Also leveraging on the existing community-based support network is very important. Next slide. Here is the concepts which are picked from e-hospice that give us the critical element or construct of building a compassionate communities. And the major thing is to have a compassionate communities made up of people. You need to make sure you have compassionate individuals. Then we have a compassionate relationship with one another. We have a compassionate organization or community-based organization that have a compassion for the people they serve. Then you can have a compassionate communities. Next slide. It is like a tree from the roots to the shoot. There are the different phases of developing a community capacity which can provide compassionate care for one another, especially in chronic condition or life-limiting conditions. Next slide. So this one I've tried to add it. As a Uganda Cancer Institute, having realized that cancer experts are very few, and the need for their services is very high, training them very expensive abroad, but you have experts from Africa, from Uganda who are trained in Europe. They still have connection with the people who train them. From the university where you are trained, you say, why don't we train for the African population? So we have opened a cancer fellowship training at the Uganda Cancer Institute. It is a hospital, but also providing training, what we call an academy. Currently, in the early this year, we graduated a number of fellows in the area of gynecological oncology, pediatric oncology, hematological oncology. As I speak now, we also open a course on radiation oncology. So that we train the experts. Our experts who are trained abroad, they're still living. Many of them are all now are retiring soon. We say, let's not lose their resources like that. All the knowledge they got from the UK, they got from Germany. If they retire and die with it, that's a very big loss for Africa, very big loss for this poor country. You're saying, become the trainer, train these people here. So you're providing a training here, fellowship. People have their master's degree in any area of the medicine can now enroll here. We encourage even other African countries who cannot afford to train somewhere else, can also, who have passion for fighting cancer, can also train here. But you collaborate with the different universities. You have collaboration with the Cambridge, you have collaboration with the Fred Hutch in the US, you have collaboration with the National Cancer Center of South Korea to make sure we have a quality training for these professionals. So what they call the UCI Academy, to build capacity to meet the need of the cancer control needs. Next slide. We are also saying, let's improve cancer surveillance in the country. For the long time, we have been having two cancer registries, the Kampala Cancer Registry, which is the longest cancer registry in Africa, which was established in 1954. It is still working up to now, the longest cancer registry in Africa. But it also opened the Gulu Cancer Registry in 2013. But now the government of Uganda has accepted that we open additional 4 regional cancer centers in this area which are marked on the map here. The Mbale Regional Cancer Center in southwestern Uganda, the Mbale Regional Cancer Center in the eastern Uganda, and then the mid-north Uganda. As I speak now, the Gulu Regional Cancer Center for northern Uganda now complete and it's now working. The one from Mbara also now working. Now the government looking for resources to construct the Regional Cancer Center in Arua for the northwestern Uganda, and then the one for the eastern Uganda. But under those proposed regional cancer centers, we are saying let's have a robust, acceptable population-based cancer registry, which could be acceptable by IAC. IAC is the International Agency for Research on Cancer. Currently, IAC accepts only two of our registries, the Kampala Cancer Registry, the longest time series registry in Africa, and then the Gulu Cancer Registry. But I'm saying with the other three cancer registry, later on, we need to make them to the standard where that data quality is acceptable to IAC, so that we can well define the burden of cancer in each of those sub-regions, so that we know which cancer affecting our people, which cancer killing our people most. Currently, we are relying with the data projected from the two registry, which may not be representative for the entire country. But I say if you have all the critical aspect of the segment of the country is a map with the cancer registry, we are able to provide evidence-based cancer control for our population. Next slide. In conclusion, we are saying building cancer resistant and also compassionate communities for cancer control are social model of care and support, where communities are proactive in mobilizing resources for cancer control to support the little resources that the government provide, that the donors provide, so that they're also contributing to the fight against cancer is a way to go in ensuring that we build a cancer-resistant communities, at the same time, a compassionate communities that can hold the hand of one another in the situation of life-limiting disease like cancer. The last slide is my reference. Thank you for listening.
Thank you. And immediately, I must say to our audience that we will make, I'm sure Dr. Alfred will be happy if we make available his slides, because there is lots of information on several of them. But first of all, I must say what a tour de force your presentation was, Dr. Alfred, and I think you must have frightened the internet into behaving, because you managed after the first couple of hiccups to make sure the internet stayed listening and enabled us to listen to really a fabulous presentation. The content really interesting, some of the technical clinical issues that you described are so important, but most of all, I think your passion about compassionate communities, about what's needed. And I have loads of questions and opportunity to discuss further with you, but time is going to run out, I'm afraid. And we have to blame the internet for that, but absolutely fantastic that you managed to stay joined with us. So we really heard the detail, but also the passion around compassionate communities, the passion around the politics with a big and a small p of the impact of chronic diseases that can be prevented and how they can be prevented even in the most vulnerable low-income communities. So I want to stay engaged and to learn more from you, and I'm sure others do. We will, if you're happy, circulate your slides, and we will be pleased to forward any comments or questions from any of the audience. But because we're part of London Global Cancer Week, I know that some people will be committed to another event almost straight on. So I'm really going to thank you wholeheartedly for a really inspiring and really useful to us in C3, who have a significant community engagement program that we've used mainly in the UK and in parts of Europe. And you've really given us some ideas. And one of the things that's so clear is community engagement for prevention needs strong leadership and drive. And I think, Dr. Alfred, you've definitely shown us that that's what's driving the change in Uganda. So my sincere thanks to you. My thanks to our colleagues, particularly Richard at Global Health Partnerships, formerly THET, who introduced us to you, and that introduction will continue, I'm absolutely sure. And to invite everybody to our next international seminar, which will be a C3 international seminar, where we have joining us the Director of Policy of NCD Alliance, to pick up and build on the UN high-level meeting that took place in New York in September to see what the impact and the changes within NCDs, and particularly NCD prevention, can emerge from those sorts of global events. So my thanks to our participants, none of whom left when the internet left, all of whom stayed, and a special thanks once again to Dr. Alfred, and such wonderful wisdom, and we will certainly stay in touch and learn more from you. Thank you. Thanks to everybody. Goodbye.
Thank you so much, Christine, and the rest. Bye-bye.